In this lecture, we'll discuss medical nutrition therapy for hepatobiliary and pancreatic disorders. So the liver, gallbladder, and pancreas are considered accessory organs to the GI tract. So all three organs are important for proper digestion, absorption, and metabolism of nutrients, but remember they're not actually doing this digestion and absorption themselves. So the liver and the pancreas are essential, so you can't live without them, but the gallbladder can be removed and the body will adapt. And so the hepatobiliary system refers to the liver, pancreas, gallbladder, and bile ducts. Now looking at the anatomy of the liver, so this is the largest internal organ, and it's located in the right upper quadrant. So again, if this is the anatomical right, so this would be on your right side, again, it's basically half under your rib cage. Now it's brownish red in color when healthy, and it has two functional lobes. So you have, in essence, the right side, which receives blood from the right hepatic artery, and the left, which receives blood from the left hepatic and middle hepatic arteries. Now each lobe is made up of thousands of lobules around a central vein, and so the lobule is the functional unit of the liver. Now the liver can store approximately 200 to 400 milliliters of blood, and one of the defining characteristics of the liver is that the cells of the liver are resilient and can actually regenerate. So this is one of the only organs that can actually regenerate itself. So again, similar to the lizards, right? When a lizard loses its tail, it regrows a tail. You know, if you were to lose a finger in an accident, you don't regrow a finger. But if you lose part of your liver, you can regrow your liver. And so again, these cells are referred to as hepatocytes, and only 10 to 20% of a functioning liver is needed to sustain life. Now again, we said that the liver is supplied with blood from the hepatic artery, which brings oxygen-rich blood from the aorta to the liver, as well as the portal vein, which brings nutrient-rich blood from the intestines, spleen, and pancreas to the liver. Now approximately 1,500 milliliters of blood per minute circulates through the liver and exits via the right and left hepatic veins into the inferior vena cava. So remember, that is the large blood vessel below the heart. And the hepatic vein returns blood from the liver to the heart. And so here we can see, again, as we actually absorb the nutrients through the intestines, again, how they then have a direct route through the hepatic vein into the liver, and we can then see how the liver is directly below the heart. And here again, if you wanted to see that we also have the blood flow with the stomach, so the previous photo just showed the large intestines, but here you can also see the stomach as well as the circulation from the liver to the heart. Now looking at the functions of the liver, so the liver has over 500 known functions, including carbohydrate, lipid, and protein metabolism, bile acid synthesis and secretion, enzyme metabolism, vitamin storage and activation, including B12, A, D, E, and K, detoxification and excretion of endogenous and exogenous wastes, including ammonia, the conversion of ammonia to urea, the metabolism of steroids, and the synthesis of coagulation factors for blood clotting. Now we also have in the liver what are known as Kupffer cells, and these are macrophages located in the walls of the liver sinusoids, and these remove bilirubin, dyes, bacteria, damaged red blood cells, and other debris or toxins from the plasma through phagocytosis. And so these sinusoids, remember, these are microscopic blood channels or capillaries in the liver. So when we talk about the fact that the kidneys and the liver are responsible for detoxification, this is one of the mechanisms for how the liver actually performs that function. And so here you just see, again, what's known as a sinusoid, which would be a cavity or channel. So again, just giving you an idea of then where these cells would be lining this cavity to then actually break down these toxins. Now looking at bile, so this is a thick viscous fluid made by the liver, stored in the gallbladder, and released into the duodenum when fatty food enters the duodenum. Bile is composed of bile salts, bile pigment, cholesterol, neutral fats, phospholipids, and electrolytes. Now the bile works as an emulsifying agent that helps in the absorption of fatty acids, monoglycerides, cholesterol, and other lipids by forming micelles that are soluble in the watery chyme. And 95% of bile salts are reabsorbed into the blood from the small intestine in what's known as enterohepatic circulation, or the recirculation of bile. So again, you'll actually reabsorb this and continue to reuse it, with 5% of bile salts being lost in the feces. And so here we can see that process. So again, it's produced in the liver, stored in the gallbladder, and in essence is used as fuel injection into the duodenum, so it is secreted in small amounts as the chyme exits the stomach through the pyloric sphincter and goes into the duodenum. And again, when we get to the large intestine, it is reabsorbed, although not completely, where it then circulates back to be restored for future digestion. Now looking at the liver and our laboratory values, we have what's known as liver function tests. So these are non-invasive screenings for liver function and allow for the recognition of the different types of liver disease, the assessment of severity, and can help predict outcomes. And so the most common tests are looking at bilirubin, alanine aminotransferase, or ALT, aspartate aminotransferase, AST, alkaline phosphatase, albumin, and prothrombin time. And so again, this allows us to actually look at the function of the liver without having to do a biopsy, although we may need to do a biopsy depending on the condition. So remember, bilirubin is the yellow breakdown product of normal heme catabolism. And so when increased, this may indicate bilirubin overproduction or a defect in hepatic uptake. And so remember, this is what makes bruises have that yellowish green color. So again, that is the breakdown of the blood cells, right? You then have that yellowish green color from the bilirubin. ALT and AST are hepatic enzymes, and these are increased with liver damage or inflammation of the liver. Alkaline phosphatase, or ALPPHOS, an increased level suggests cholestasis, which is an interruption of bile flow, and the cause may be within the liver, or it may be external to the liver. Again, we can look at albumin, which is the main export protein that is synthesized in the liver. And so liver dysfunction will cause a decreased albumin synthesis. And again, looking at prothrombin time, so increased if there's insufficient clotting factors present. And meeting clotting factors, again, this is one of the major functions, are synthesized within the liver. Now looking at the different types of liver disease, we'll talk about acute viral hepatitis, fulminant hepatitis, chronic hepatitis, non-alcoholic steatohepatitis, alcoholic hepatitis and cirrhosis, cholestatic liver disease, inherited disorders, and others, including things like hepatocellular carcinoma. So again, hepatitis, so if it ends in itis, it's inflammation, and this is hepato, so here we just have inflammation of the liver. Now again, this can be caused by a virus, bacteria, toxins, obstructions, parasites, or chemicals. But most commonly when we say hepatitis, you're probably thinking of viral hepatitis. And there's 5 identified viruses or strains, so A, B, C, D, and E. And looking at viral illnesses, right, so we have 4 phases. So we have the early prodromal phase, where we see fever, joint pain, joint inflammation, rash, and angioedema, which is a swelling in the face and throat. We have the pre-icteric phase, where we see malaise, fatigue, muscle pain, poor appetite, and nausea and vomiting. We have the icteric phase, where the patient will develop jaundice. And then what we should see is the convalescent phase, where jaundice and other symptoms begin to subside and the patient begins to recover. Now looking at jaundice or icterus, so this is a symptom of liver disease, where again we have a yellowish tint to the body tissues caused by large quantities of bilirubin in the extracellular fluid, and so the skin will again to appear jaundiced when the bilirubin is greater than 2.4 to 3 milligrams per deciliter. And so the three causes of jaundice, so we have hemolytic, which is the increased destruction of red blood cells with a rapid release of bilirubin into the blood, which is what we typically see in pediatric patients. We have hepatic, with a decreased uptake of bilirubin by the liver and or decreased liver function. We have obstructive, where the bile ducts are obstructed, which prevents the excretion of bilirubin into the GI tract. So looking at our viral hepatitis, so we have hepatitis A, which is transmitted almost exclusively by the fecal-oral route, and this is in things like contaminated drinking water, contaminated food, or when you have sewage. And so, for example, this can occur, and you'll see there's usually boil water notices after things like hurricanes. So when you have large amounts of water, they get into the sewer system and they can cause the sewer system to overflow or back up. Or if a water treatment plant goes down, again, this is one of the reasons you will see a boil water notice. You'll see hepatitis B, which gained a lot of notoriety in the 80s and 90s. And this is transmitted via blood products, semen, and saliva. But most famously, hepatitis B is improperly sterilized medical instruments, but specifically tattoo needles. So again, now needles are actually disposable, and the ink now is actually used in small quantities for each individual tattoo. But at one point, right in the 80s and 90s, when ink bottles would be contaminated, this is why you saw there was a big fear of hepatitis with tattoos. Again, modern sanitation has kind of reduced this risk. So there's a development of cirrhosis in 15 to 25% of cases. Hepatitis C. So this is exposure to blood or body fluids from an infected person. So sharing needles or IV drug use is the most common cause. The development of cirrhosis in 5 to 20%, and there's an increased risk for liver cancer. Now there is hepatitis D, which is uncommon in the US and requires somebody to also have the comorbidity of having an hepatitis B infection. And there's hepatitis E, which again is another acute infection that doesn't have the long-term complications as often, and again is very rare in the US. Looking at fulminant hepatitis. So this is a syndrome in which severe liver dysfunction is accompanied by hepatic encephalopathy. This is also referred to as acute liver failure. And so hepatic encephalopathy develops within 2 to 8 weeks of onset. The patient's condition rapidly deteriorates, and this is often accompanied by blood coagulation disorders, renal failure, and coma, with a very, very poor prognosis. Now, what causes fulminant hepatitis is it's typically a complication from a viral hepatitis in 75% of cases, but can also be caused by chemical toxicity with exposure to poisons, excessive doses of acetaminophen, drug reactions, and poisonous mushrooms. Other causes include Wilson's disease, which is an inherited disorder that causes excessive copper accumulation in the liver, brain, and other organs due to inefficient elimination of copper, hepatic ischemia, hepatic vein obstruction, or hepatic malignancy. Now looking at chronic hepatitis. So again, this is inflammation of the liver against a form of hepatitis that lasts at least 6 months. And causes include autoimmune, viral, metabolic, and drug or toxin induced. Now the signs and symptoms are mild or non-specific, and again they are intermittent, so it gets better, it gets worse, it goes away, it gets worse, etc. Symptoms include fatigue, sleep disorders, poor concentration, right upper quadrant pain, and if severe can lead to jaundice, muscle wasting, ascites, edema, hepatic encephalopathy, GI bleeds, and splenomegaly. Now looking at the MNT for hepatitis, so the nutritional implications are weight loss and nutritional deficiency due to inadequate dietary intake, drug nutrient reactions with concerns for medications like antivirals, immunosuppressants, antacids, steroids, and antibiotics. From a nutrition assessment standpoint, we're focused on the patient's weight, food intake, lifestyle factors, and alcohol intake. And common PES statements include inadequate food and beverage intake, food medication interactions, and impaired nutrient utilization. So our interventions, again, we're focused on the nutrients needed for liver regeneration and the avoidance of alcohol. And looking at our monitoring and evaluation, again, the tolerance to the food or feedings, the amount of nutrients consumed, any weight or weight changes, looking at labs including liver function test, and again, evaluating the patient's overall sense of well-being. Again, especially if we're looking at chronic cases where, again, it can get better, it can get worse, and how the patient's managing their disease. Next, we'll take a look at non-alcoholic fatty liver disease. So this is the accumulation of fat droplets in the hepatocytes that can lead to fibrosis, cirrhosis, and hepatocellular carcinoma. So this occurs in non-drinkers and affects 1 in 10 children in the US. Now it may be genetic, but it's also tied to obesity and insulin resistance. And so the diagnosis is going to be used with liver enzymes and then an ultrasound or biopsy. And the treatment is diet, exercise, and weight loss before the disease can progress to NASH. So non-alcoholic steatohepatitis, or NASH. This is liver inflammation caused by the buildup of fat in the liver. And so fatty liver will then become inflamed and the cells will be damaged. And this is a more serious form of non-alcoholic fatty liver disease. Some patients progress to NASH and some do not. And this may be related to oxidative stress. And the early stages are reversible, but this can lead to end-stage cirrhosis. And signs and symptoms include weakness and hepatomegaly. And the treatment includes weight loss and metformin. Again, we said this disease was tied to insulin resistance. And this is common in patients with obesity and cystic fibrosis. Next, we'll take a look at alcoholic liver disease. And so this is morbidity and mortality resulting from alcoholism. So how does alcohol use actually end up killing a patient long term? So this is the actual mechanism. So again, it has toxic effects on all major organ systems, and alcoholic liver disease is the 12th leading cause of death in the US, the 3rd leading lifestyle-related cause of death in the US. And so it has serious physical, psychosocial, and nutritional implications. And there's 3 disorders included in alcoholic liver disease, including fatty liver, alcoholic hepatitis, and cirrhosis. And so fatty liver, or steatosis, is present in 90% of chronic ethanol abusers, and it's virtually asymptomatic, although hepatomegaly, or an enlarged liver, is the most common clinical sign, although it can be severe with dark urine and light-colored stools, and the patient will have slightly elevated GGT, AST, and ALT enzymes, although relatively speaking it is benign and reversible with the cessation of alcohol use, but can progress to alcoholic hepatitis or cirrhosis, which are life-threatening. Now, alcoholic liver disease. So again, liver disease caused by years of heavy alcohol consumption, with again 3 stages of pathogenesis of alcohol liver disease. So we have hepatic steatosis or fatty liver. We then develop the alcoholic hepatitis, and then alcoholic cirrhosis. And so again, this is the most common liver disease in the US. And acetaldehyde is a toxic byproduct of alcohol metabolism, which causes damage to the mitochondrial membranes, structure, and function. And so here we can see the complications of excessive ethanol abuse with excess hydrogen and acetaldehyde. And so here we can see then the actual pathway if you're actually looking at, so the quote-unquote, the toxins from alcohol use. Here you can actually see the pathway that leads to cirrhosis.
Alright, so we'll begin our second lecture on the hepatobiliary system. So as a quick review, we'll pick up where we ended our first lecture, which was on alcoholic liver disease. So the first stage we termed hepatic steatosis or fatty liver. So here we see an increase in mobilization of fatty acids from adipose tissue, increase in hepatic synthesis of fatty acids, a decrease in fatty acid oxidation, increase in triglyceride production, and a trapping of triglycerides in the liver. Now, we did say that this first step of alcoholic liver disease is reversible with abstinence from alcohol. So again, due to the liver's ability to regenerate, again, if we have an abstinence of alcohol, this stage is reversible. The second stage is alcoholic hepatitis. So again, hepatitis giving us the hint that this is inflammation of the liver, and we see hepatomegaly, which is again an enlarged liver, elevation of the transaminase or enzyme levels, increased serum bilirubin, normal or depressed serum albumin, and anemia. So again, we're going to see an increase in bilirubin as the liver is not breaking down the bilirubin for excretion, and we're going to see a decrease in albumin, which the liver is responsible for synthesizing. Signs and symptoms of alcoholic hepatitis include abdominal pain, poor appetite, nausea, vomiting, weakness, diarrhea, fever, and weight loss. Again, though, even at this stage, because of the liver's ability to regenerate, this is still reversible with abstinence from alcohol. The third stage, we see alcoholic cirrhosis, where healthy tissue has been replaced with scar tissue, which blocks the flow of blood through the liver, resulting in a loss of liver function. And again, as we discussed previously, chronic hepatitis C accounts for 26% of cases for alcoholic cirrhosis. 26% of cases of cirrhosis, and alcoholism accounts for the other 21% of causes of cirrhosis. Now again, not all heavy drinkers will develop cirrhosis. Again, part of this is based on a timeline and total alcohol intake along with personal physiology. Again, the prognosis does depend on, again, abstinence from alcohol. As we discussed in previous slides, we only need 10 to 20% of a functioning liver to support life. Again, depending on how much of the liver has been damaged and replaced with fibrotic scar tissue, again, abstinence from alcohol still may improve prognosis and recovery. Again, looking at cirrhosis, which is that replacement with scar tissue, we see an enlarged liver, hepatomegaly, with fat accumulation and necrosis of liver cells, ascites and edema, elevated enzyme levels, vitamin and mineral deficiencies, depressed hemoglobin and hematocrit, which goes with that previously discussed anemia, the presence of gallstones, portal hypertension, which we spoke about was a specific form of elevated blood pressure, and this is through the blood flow through the blood vessels that run through the liver, and we'll talk more about this in detail. Hepatic encephalopathy, hepatorenal syndrome, and esophageal varices. Again, symptoms for cirrhosis, we'll see jaundice, dark urine and light or clay-colored stools, steatorrhea, fatigue and weakness, nausea, abdominal pain and bloating, poor appetite, delirium tremens or the DTs, fever, GERD, diarrhea, and bruising or bleeding, which again is tied to that change in clotting factors, hemoglobin, and hematocrit. Here we can see, again, looking at the symptoms and their physiological signs and symptoms, as well as internal symptoms. Again, just take a look and just look at a variety of different conditions that can arise from cirrhosis. Again, in this case, we're usually referring to is alcoholic liver disease, but also in the case of hepatitis C. Nutritional implications we spoke about previously were early satiety. Again, this is due to ascites, which we'll discuss, which is a buildup of fluid in the abdomen, impaired digestion and absorption due to portal hypertension, decreased enzyme production, and villus atrophy. Remember that alcohol is responsible for gastritis. Again, so we're going to see that blunting of the villi in the small intestine. Increased energy expenditure with vasodilation and increased blood volume, hypoglycemia with hyperinsulinemia, and again, because of that cirrhosis and that replacement of liver tissue with fibrotic scar tissue, we will see a decrease in liver glycogen. And remember, liver glycogen is one of the ways that we can regulate blood glucose, and we may also see diabetes and or hyperglycemia, again due to insulin resistance. So our goal is looking at, again, we spoke previously that alcohol supplants food in the diet, poor appetite, malabsorption and maldigestion with inflammation of the stomach, pancreas, and intestine, and increased excretion and destruction of specific vitamins. So here we're looking at urinary excretion of folate B6, and thiamine. Looking at dietary intake and intolerances, lifestyle factors including alcohol intake, labs, and medical history. So again, has the patient ceased alcohol intake? Are they continuing to drink alcohol? What is their current status of their liver, their medical history? Again, is this an acute bout? Is this a chronic condition? We'll speak about a little bit later our goal for obtaining their dry weight, which is without fluid buildup in the system. And again, because we don't want to account for that fluid when we're doing our physical assessment, we want to consider tricep skin fold, mid-arm circumference, and the subjective global assessment. We also want to take a look at socioeconomic status and labs. Again, what we're looking at is looking at long-term planning conditions and solutions for this patient to improve their nutritional status. Again, is this meal delivery? Is this part of their recovery, etc. Looking at possible diagnostic statements for cirrhosis, we have if the patient has ascites, we can use excessive sodium intake or excessive fluid intake. If there's the presence of esophageal varices, we may use swallowing difficulty, inadequate oral food and beverage intake, or disordered eating patterns. If the patient has encephalopathy, this may be due to excessive protein intake or inappropriate intake of aromatic amino acids or our branched chain amino acids or the ratio. If the patient is suffering from hepatorenal syndrome, this may be signs for using the PES statement, excessive sodium intake. Again, we're taking a look at energy needs. So what we're seeing is 120 to 140% of resting energy expenditure if there is no ascites. This is the equivalent of saying 1.2 or 1.4 as our stress factor. If the patient does have ascites, infection, or malabsorption, we would recommend 150 to 175% of resting metabolic rate. This is again saying the same as 1.5 to 1.75 for our stress factor. You may also use 25 to 35 calories per kilogram of dry weight. For protein, in uncomplicated cases of cirrhosis with the no presence of hepatic encephalopathy, we recommend pretty close to normal recommendations of protein at 0.8 to 1 gram per kilogram. If the patient is stressed due to sepsis, infection, GI bleeds, or severe ascites, we'll recommend increasing the protein to 1.5 grams per kilogram. And the controversial restriction of protein is if there is severe hepatic encephalopathy, in which case we recommend 0.6 grams per kilogram. Now, it is important to note that this is in severe cases and if we have to consider other comorbidities. If the patient has significant trauma, wounds, etc., again, we have to take into account for priority what is most likely to impair the quality of life first. Is this septic wounds? Is this the hepatic encephalopathy? Again, there is medication to treat excess ammonia. We'll talk about that a little bit later. Vitamins and minerals, again, our concern here, and we talked about is that excessive sodium intake or fluid intake. Again, looking at the presence of sodium, fluid retention, and increasing blood pressure. So we recommend a sodium intake of less than 2,000 milligrams, and a multivitamin with mineral supplement is commonly indicated. Depending on the severity of the condition, the patient may need enteral or parenteral nutrition, or they may just need a mechanically soft diet for the presence of esophageal varices. Things to monitor: tolerance to feeds. So again, with the esophageal varices, is the food well tolerated? If you're using enteral or parenteral, is it tolerated? The total amount of nutrients consumed. Changes in dry weight, so this is important again while we're taking a look at tricep skin fold and mid-arm circumference, is we don't want to just account for fluid, but actually taking a look at the change in the patient's mass. Review of the labs, again focusing on ammonia, hemoglobin, hematocrit, liver enzymes, etc. And cognitive status, which again is one of the hallmarks for hepatic encephalopathy. Looking at vitamin and mineral intake in alcoholic liver disease or in alcohol dependency, we previously spoke about thiamine deficiency, which we know as beriberi. However, there is a unique form when there is alcoholic dependency involved, known as Wernicke-Korsakoff syndrome. So this is thiamine deficiency in patients suffering from alcoholism, and what we see is known as Wernicke encephalopathy, which is an inflammatory, hemorrhagic, degenerative condition of the brain. This is characterized by lesions or damage to the brain, confusion, ataxia, double vision, and involuntary rapid movements of the eyes. This is caused by a thiamine deficiency and is associated with chronic alcoholism. Again, what you will see in what's known as a banana bag is going to contain the B vitamins, again with the concern of preventing this from happening in hospitalized patients with alcohol dependency. So we'll move on from alcoholic liver disease to primary biliary cirrhosis. So this is caused by progressive destruction of the small intermediate-sized intrahepatic bile ducts. The extrahepatic bile ducts and larger intrahepatic ducts are normal. This eventually results in portal hypertension, cirrhosis, and requires either a liver transplant or will result in death. Unfortunately, we do not know the cause of this illness, but it is thought to have an autoimmune component, and it is more common in women. So again, here we see another cause or a disease with replacement of tissue with scar tissue, but here again we don't know the cause versus the previous disease. Clinical manifestations of primary biliary cirrhosis include cholestasis, osteopenia, hypercholesterolemia, and fat-soluble vitamin deficiencies. The treatment for this is ursodeoxycholic acid, or UDCA, also known as ursodiol, such as Actigol or Urso. So this bile acid that helps move bile through the liver. This does not cure primary biliary cirrhosis, but may slow the progression of the disease and prolong life if started early in the disease process, and is considered the first-line therapy. The long-term treatment is a match for a liver transplant. Sclerosing cholangitis. Here again we may recall that sclerosing refers to hardening, and itis again looking at inflammation. And so here we have a chronic disease that slowly damages the bile ducts inside and outside the liver. Here again, so we have that fibrosing or hardening of the tissue, so inflammation of segments of extrahepatic bile ducts with or without the involvement of intrahepatic ducts. This can lead to portal hypertension, hepatic failure, and cholangiocarcinoma. Again, unfortunately, has an unknown cause, but may be an autoimmune disorder or have an autoimmune component. Clinical manifestations for sclerosing cholangitis include fat-soluble vitamin deficiencies due to steatorrhea, hepatic osteodystrophy due to vitamin D and calcium malabsorption, resulting in secondary hyperparathyroidism, osteomalacia, and rickets. Now what's interesting here is that we can possibly see the treatment of ursodeoxycholic acid, again similar to the previous condition. Unfortunately, this will improve laboratory values, but does not have an effect on survival. So this treatment does not slow the progression of the disease as it does in other diseases. So UDCA is not a viable treatment for sclerosing cholangitis. Now you've seen, as we've spoken about, multiple liver diseases with fibrosing or the development of scar tissue within the liver. We can develop what's known as portal hypertension. So here we're looking at, again, hypertension being elevated blood pressure, and here we're going to be taking a look at portal circulation or through the portal vein. So here we have elevated blood pressure in the portal vein due to the buildup of scar tissue, and our primary symptoms are ascites, which is the accumulation of fluid within the peritoneal cavity, GI bleeding from varices, which are swollen veins in the GI tract, and encephalopathy with reduced mental capacity and consciousness. Again, we spoke about that bleeding varices. So again, these are very similar to hemorrhoids, but instead of being in the rectum or anus, these bulging and then possibly bleeding blood vessels are going to be found in the esophagus, in which case it may be impossible for the patient to consume food orally or to successfully place a tube such as an NG tube or an OG tube down the patient's throat, and they may require parenteral or IV nutrition. Here we can see what is meant by ascites. So again, we have the presence of a large amount of fluid in the peritoneal cavity. And so you can see, so that is not fat mass, that is actually fluid. This can be drained from the body in a process known as a paracentesis It's very similar to tapping a keg, in which case a large needle is inserted into the cavity and the fluid is drained. Now what's very important is why this occurs. And so looking back previously at the function of the liver, we can kind of understand this a little bit better. So one of the primary functions of the liver is the production of albumin. Now albumin, which goes back all the way to MNT1, we talked about the maintenance of blood pressure. And so we said specifically there was a balance of osmotic pressure, hydrostatic pressure, and oncotic pressure. And so we know that the force of the fluid in your blood vessels will cause fluid to leak out. Conversely, we know that the proteins and electrolytes in the blood will pull fluid back into the blood vessels. The primary molecule that can achieve this is albumin, as it is too large to exit through the capillaries. Now, when you have severe damage to the liver, you will have decreased osmotic pressure as the liver is no longer synthesizing enough albumin. So we have a patient with hypoalbuminemia, and they will be unable to produce enough albumin to pull water back into the blood vessels. So what happens is you have excessive amounts of fluid are leaking out, and they are specifically leaking out into the peritoneal cavity. This condition is complicated by the fact that we also have systemic arterial vasodilation with cirrhosis. This increases the release of aldosterone, which increases the absorption of sodium and fluid, further increasing blood pressure, causing even more fluid to leak out into the peritoneal cavity. Now the treatment for this we discussed is a paracentesis, and this is a procedure in which fluid is withdrawn from the abdominal cavity via a catheter, and this is very similar again to tapping a keg. And now what we do see is that the peritoneal cavity can hold up to 15.5 liters of fluid, and we recall that 1 liter of fluid weighs approximately 1 kilogram. So if a patient has had a paracentesis and they've been drained 10 liters of fluid, they will have also lost 10 kilograms, or approximately 22 pounds. And so I have seen in practice many times what I thought to be a weight error, or it's reported by the nurse that the patient lost 20 pounds in a single day. I've often thought to myself that perhaps somebody recorded the weight in error, but upon further investigation and actually speaking to the patient and to the nurse, you discover they performed a paracentesis, in which case it is possible to see very large fluctuations. And again, while this is not truly malnutrition, we do need to take into account that this paracentesis is not without a cost. And so what we know is that there's approximately 1 to 2 grams of protein in every 100 milliliters. This also means that there's approximately 10 to 20 grams of protein in each liter. If a patient is being drained of a significant amount of fluid via paracentesis, for example, 10 liters, that is approximately, we would say that 1 times 10 is 10, times a further 10, which would be 10 liters, tells us that there's approximately 100 to 200 grams of protein lost in the fluid removed from the patient. Along with the paracentesis and the management of ascites, the patient will also be on a sodium restriction and diuretics. So we want to excrete the fluid and reduce blood pressure so that less fluid leaks into the peritoneal cavity. Now there are some complications with ascites. We can develop what's known as bacterial peritonitis, which is a bacterial infection. So the fluid itself, can grow bacteria, causing an infection and an inflammation of the peritoneal membrane. We also have what's known as hepatorenal syndrome, so renal failure associated with severe liver disease. And again, this is usually progressive and fatal. Part of the cause of ascites is this elevated blood pressure or portal hypertension. So we can treat the actual cause rather than treating the symptoms. This is achieved with what's known as a TIPS procedure, or transjugular intrahepatic portosystemic shunt. And in essence, what we're doing is we're going to reroute blood flow through the liver, relieving pressure in the veins, reversing the tendency for bleeding and fluid accumulation, and reducing that portal hypertension. So here you can see we have placed a shunt, in which case we have in essence created a man-made alternative pathway for the blood to flow and reducing the blood pressure through the liver. In addition to ascites, we've consistently discussed hepatic encephalopathy showing up with multiple liver conditions. So to review hepatic encephalopathy, we have a syndrome of impaired mental status, abnormal neuromuscular function, and altered consciousness due to liver failure. Signs and symptoms include changes in mental status, personality, and confusion with neuromuscular changes. The most famous of these changes is asterixis, which is brief intermittent movements of individual fingers in a flexing motion, also called hand flapping or the flaps. I would recommend that you YouTube this, and you can look up asterixis, and you can see it's a very distinctive movement pattern that happens in certain disease states. So there are 4 stages of hepatic encephalopathy that are dependent on the degree of liver failure and are increasing in severity. So stage 1 is accompanied with mild confusion, agitation, irritability, sleep disturbance, and decreased attention. Stage 2, we see lethargy, disorientation, inappropriate behavior, and drowsiness. Stage 3, the patient will be somnolent but arousable, incomprehensible speech, confused, and aggressive behavior when awake. And stage 4 results in a coma. Unfortunately, we're not exactly certain what causes hepatic encephalopathy, but we believe it's an inability to eliminate toxic products to the brain, and so we currently have several major hypotheses or theories to explain neurotransmission impairment. So we have what's known as ammonia accumulation, synergistic neurotoxin, and then the false or altered neurotransmitter theory. So the most common theory and probably the most well known is the ammonia theory. And again, we've discussed ammonia previously, so again, it's very famous, used, for example, in all the movie scenes when somebody has been knocked unconscious and you see them want to awaken the patient. And this is done with ammonia. Again, this is a toxic substance that even when you are unconscious, your body will make an effort to get away from. So it does release adrenaline and causes the body to try and avoid it. Now what happens is that because the liver is not functioning, it is not able to break down ammonia into urea. So remember, the primary role when it comes to the metabolism of protein is we will have ammonia, but this will immediately be broken down into urea, which will then be eliminated from the body through urine. With your liver not functioning, ammonia will build up in the body, and this is directly toxic to the brain. So this is from the breakdown of proteins, amino acids, purines, and pyrimidines. Ammonia accumulates in the blood as we have a decreased ability to detoxify it. And the main source of ammonia is endogenous production from the GI tract, from metabolism of protein, and the degradation of bacteria and blood from GI bleeds, also taking into account exogenous protein. And this is why we talked about with severe cases of hepatic encephalopathy, we will restrict that exogenous or dietary protein. So studies show a positive correlation between blood ammonia levels and abnormalities in mental state. But this does not account for all causes and cases of hepatic encephalopathy. 10% of patients will still present with hepatic encephalopathy while having normal ammonia levels. Our other theory is the synergistic neurotoxin theory, in which case we believe that neurotoxins produced by intestinal bacteria are causing hepatic encephalopathy. And our other theory is the false neurotransmitter theory, enhanced uptake of branched-chain amino acids by the muscle, lowering the plasma branched-chain amino acid and aromatic amino acid ratio, producing toxic false neurotransmitters. We also see that high ammonia levels stimulate glucagon secretion and enhance gluconeogenesis from amino acids. This causes hyperglycemia, which stimulates hyperinsulinemia. The reason why this is relevant is we know that insulin is used as the storage hormone, and this enhances the uptake of branched-chain amino acids by the muscle, again lowering the plasma levels of branched-chain amino acids relative to the aromatic amino acids. And so we do see that a low branched-chain amino acid to aromatic amino acid ratio correlates with chronic liver disease. Again, this is not causative. You don't need to supplement branched-chain amino acids to prevent this. Again, what we see though is this is what happens in patients with chronic liver disease is a change in their amino acid ratio in their blood. Now, as a review, again, typically branched-chain amino acids are referenced in the sports realm, but they do play a role in clinical nutrition. So the branched-chain amino acids are leucine, isoleucine, and valine. The aromatic amino acids are tryptophan, tyrosine, and phenylalanine. And we see a higher amount of aromatic amino acids in the brains of patients with liver failure. So this balance is restored by administration of branched-chain amino acids, which can be metabolized by the skeletal muscle rather than the liver. And so again, the rationale for the use of branched-chain amino acids in the treatment of hepatic encephalopathy, again, I don't have peer-reviewed text. What we are looking at instead is we're looking at empirical medicine and looking at expert opinion, which is the mechanism makes sense, but again, we don't have a peer-reviewed article that shows a clinical trial in which case subjects were supplemented with branched-chain amino acids and saw significant improvement. So our goal for the treatment of encephalopathy is to decrease serum ammonia levels. Here again, you'll see that we may decrease protein intake to 0.6 grams per kilogram while still maintaining a minimum of 50 grams a day. You may also see there are some aggressive practitioners that will use things such as plant sources and casein, which may improve mental status, as they are naturally lower in aromatic amino acids and higher in branched-chain amino acids when compared to meat-based diets. The other main treatment is lactulose, and this stimulates the passage of ammonia from body tissues into the gut lumen and inhibits intestinal ammonia production. So lactulose, you will see, depending on the nature of the patient, in the case of a patient with hepatic encephalopathy, its primary usage is for the excretion of ammonia, but it can also be used as a laxative. So make sure that you're reading your patient's history and physical and taking a look at their previous diagnoses before assuming why they are on lactulose. We may also use antibiotics to decrease intestinal concentration of bacteria that can produce ammonia, again looking at that false neurotransmitter theory. And probiotics and symbiotics may help improve hepatic encephalopathy, again through competition with bacteria in the GI tract. Alright, so we'll take a look now again at some specific liver diseases. So we have polycystic disease or polycystic liver disease. And so this is a rare condition that causes, you guessed it, cyst, in this case fluid-filled sacs or cysts, to grow throughout the liver. If the cyst is large enough, it can cause discomfort and health complications, but many people live with polycystic liver disease and have no symptoms. So the reason or cause of these cysts seems to be a genetic risk factor, increased age, and if you are also prone to cysts such as polycystic kidney disease. If it's severe enough or there are enough cysts, we may see abdominal pain. The cyst may bleed or become infected depending on if they rupture. The bile duct may be obstructed, leading to jaundice. Treatment is usually not needed as mild pain can be treated with medication, but if severe enough, we can perform what's known as cyst aspiration, we being the medical community. The cyst can be drained if it's blocking a bile duct or infected, in which case you may also require antibiotics to clear the infection. And again, because of the liver's ability to regenerate, if the cysts are in a specific lobe, then we may perform a liver resection in which case the cysts will be removed and the liver can regenerate. If severe enough and causing permanent damage, a liver transplant may be necessary. So you can see the next few slides are several pictures. So we can see a normal liver, again with that reddish brown color, very similar to what you buy at the supermarket. Here we can see from chronic hepatitis. Here we can see sclerosing cholangitis. Here we can see damage from primary biliary cirrhosis, again that buildup of scar tissue. And here you can see with polycystic liver disease, so in the foreground or in the front you can see a normal liver, and in the back you can see, and now this is an extreme case, in which case you can see there are cysts throughout the entire liver, which is why there's this liver was removed from the patient. So this is from a transplant, in which case, right, so that liver is at the extreme where a transplant was necessary to save the patient's life. Now again, we talked about what's unique is that the liver does have the ability to regenerate. So for certain diseases, as we previously discussed with polycystic liver disease, we may perform what's known as a liver resection or ablation. So this is a fairly common practice, in which case I'm going to remove the damaged portion of the liver and allow your liver to do what it does, which is repair itself and regenerate. Now because of this increased growth of tissue, right, we are going to need extra calories and protein. So optimal nutrition is important for hepatectomy or removal of that liver portion. Again, this may be done in cases of hepatocellular carcinoma or cholangiocarcinoma. So for example, in some types of cancer, just remove it is not an option. So I don't know how many of you are Jeopardy fans, but for example, Alex Trebek has pancreatic cancer, as did Patrick Swayze. The solution is not just remove the pancreas. Again, we've talked about previously that the pancreas is necessary for survival. In the case of the liver, sometimes, if we get lucky, it really is that simple. Just remove the diseased portion, cut it out of them, make sure it didn't go anywhere, finish up our treatments. Now, if the damage is severe enough, and so we've talked about several diseases that require a liver transplant as a treatment option. So here we have cases of end-stage liver disease, where the effects of liver disease have a greater potential to cause death or mortality than the short and long-term complications of transplant. So the most common medical conditions that actually require a liver transplant are chronic active hepatitis, cirrhosis, or a biliary-related disorder. Remember, that was that small family of autoimmune disorders that, again, typically required a transplant for a long-term solution. Now, what we do have is known as the Model for End-Stage Liver Disease, or MELD, or you may have heard what's known as a MELD score. So this is a scoring system that determines a patient's eligibility to be placed on the waiting list for transplant. So, in kind of a strange, ironic twist, you have to be sick enough to make it on the list, and sick enough or in the right position to get a transplant. But hopefully you're not too sick that the transplant goes well. So the MELD score includes serum bilirubin, creatinine, and INR to determine your score, with the range from 6 being less ill to a 40 being severely ill, and a score of at least 20 required to be placed on the transplant list. So the individual score determines how urgently a patient needs a liver transplant within the next, it's a 3-month window. Now taking a look at our survival rates, again, we're pretty successful when it comes to liver transplants. So our 1-year survival rate is 86.4%, 5-year survival rate is 72.9%, and our 18-year survival rate is 48%. Now again, depending on the age, right, for an 18-year transplant, again, you see that significant drop-off with about a 50-50 shot, but realizing that over 18 years, these patients may have other medical conditions, comorbidities, etc. Like all transplants, patients are on lifelong immunosuppression drugs to prevent rejection. This is for all transplants, whether they be intestinal, kidneys, livers, hearts, etc. So the nutritional implications, so dietary management is going to be individualized, but before transplant, our goal is to lessen the effects of malnutrition and complications of liver disease. After transplant, Again, we have the risk from the surgical stress or the needs to heal, post-intervention complications, again, our post-operative protein breakdown, periods of fasting, the side effects of medications, and the avoidance of foodborne illness. Early nutrition support, if necessary, needs to be initiated, again, to make sure that the transplant is getting all the nutrients and as much time to heal as possible. So things you're looking for if you do work in transplant. So there actually is a facility. So we do have a graduate who is a transplant dietitian. So they work exclusively with patients who are getting or who have already received a transplant. And what you are looking at is their subjective global assessment, anthropometric measurements to again account for fluid versus actual mass changes, their dietary intake, GI symptoms, lab values, and again, we've spoken previously about the side effects that we need to monitor from prednisone, being that insulin resistance with hyperglycemia, hyperlipidemia, sodium retention, so again, that elevated blood pressure due to sodium retention, nausea, vomiting, and then also we talked about that increased appetite and weight gain, and also taking a look long-term at bone health. Possible diagnoses for patients with liver transplants include increased energy expenditure, malnutrition, inadequate energy intake, altered GI function, impaired utilization, food-medication interactions, or involuntary weight loss. So our goal is to meet the needs for the patient for healing status post-transplant. Again, our preferred route is oral. If they're unable to eat enough nutrients, we talked about that aggressive early enteral nutrition support. So again, with the liver being where the actual transplant is, unless something's gone terribly wrong with surgery, we should be able to access the GI tract and use enteral nutrition. But if necessary, we may need to use parenteral nutrition, though this does put some stress on the liver. We said that calorie needs will be 15 to 30% higher than normal, with increased protein needs of 1.5 to 2 grams per kilogram per day of protein. Again, due to the medication prednisone, we are worried about insulin resistance and hyperglycemia, with a sodium restriction of 2 to 4 grams of sodium per day to avoid elevated blood pressure. Calcium and a multivitamin may be beneficial, and a thorough education on food safety. So again, we want to make sure that we're avoiding foodborne illness. So again, while we may normally been able to risk it with things like sushi, raw oysters, undercooked meats, etc., again, that carries a much higher risk when you're taking large doses of prednisone, which will decrease your immune response, and you have an organ that will be directly damaged or affected by that foodborne illness. So we do want to make sure these patients, right, are avoiding things like oysters on the half shell, anything that's not well done, true sushi, etc. So you're going to monitor their intake, their tolerance, those weight changes, again, looking at fluid versus actual mass changes. If there are any incidences of foodborne illness, they need to be reported immediately. They should be contacting their doctor. You should not be the first one to hear about this, but it never hurts to ask. And again, keeping an eye on nutrition-related complications from the medication interaction. So again, long-term, we want to keep a look on their bone health, blood pressure, weight, and blood glucose. All right, so that's enough about the liver. Let's talk a little bit about the gallbladder or the biliary. So here we have biliary disease, which affects 20 million Americans per year. And so remember, you can see from the text, it's usually done in layers. So the gallbladder is located on the underside of the liver and on the right side of the abdomen. So again, the biliary tract is the path that takes bile after it's secreted from the liver to the small intestine. So here we can see a diagram from underneath. So again, you can see, again, it would normally not be in quite this setup, but some of the anatomy has been shifted so that you can see. But in essence, the gallbladder looks a lot like a deflated latex balloon. So its function is to increase the concentration of bile by removing water and electrolytes. So this is our storage location. and it controls delivery of bile salts into the duodenum, again via fuel injection. So after eating a meal, CCK, or cholecystokinin, is released from the mucosa of the small intestine, and this stimulates the gallbladder to contract and deliver bile into the proximal small intestine via the sphincter of Oddi. So the proximal small intestine means at the beginning of the duodenum. So it's going to do it early on. So proximal meaning at the beginning portion, not further down. So bile salts are necessary for emulsification of fat, which again must occur before lipids can be digested and absorbed in the watery gastric juices. So again, we've previously talked about this in class. We're taking a look at things like your French vinaigrette, which uses mustard, again, your cake, which uses egg, your chocolate, which uses soy lecithin. Again, here in the case of digestion, we're using bile to allow the fat from, for example, French fries to be digested, right, and allow that fat to mix with the gastric juices for digestion and absorption. Now what we can check for if we're looking at function of the gallbladders, we can do an ultrasound to locate gallstones. We can also do what's known as an ERCP, or endoscopic retrograde cholangiopancreatogram, which allows us to view the structure of the common bile duct, other bile ducts, and the pancreatic duct. We can also use this to treat narrow areas or strictures of the bile ducts and remove gallstones from the common bile duct. So if there's a narrowing, we can provide a dilation or a small stretching, and that's usually our first line of treatment. If it's severe enough, again, we'll talk about that in a few slides about removal of the gallbladder, but ideally we could simply stretch the opening to make sure that there's no blockages. So some terms for the gallbladder. So cholecystitis, so you guessed it, with itis, we're going to have inflammation of the gallbladder. Cholelithiasis is the name for the presence of gallstones. So chole for the gallbladder, lithiasis for stones. So when we do a future lecture on nephrolithiasis, you guessed it, nephro, kidney, lithiasis, stones. Cholestasis. So here we have the gallbladder, in which case it is static or stasis or paralyzed, in which little or no bile is secreted, or the flow of bile into the digestive tract is obstructed. We also have choledocholithiasis. So again, similar to cholelithiasis, we have some kind of stone in the gallbladder. In this case, this is a biliary obstruction. We have cholangitis, so an inflammation of the biliary ducts secondary to obstruction of the common bile duct. And then cholecystectomy, again, chole and ectomy, so we're looking at removal of the gallbladder. So our first disease we'll take a look at is cholestasis or biliary stasis, or again, some kind of stasis or paralysis of the gallbladder. And so in this condition, we have little to no bile being secreted, or the flow into the digestive tract is obstructed. So this can occur in patients without oral feeding or enteral nutrition for a prolonged period of time. Since cholecystokinin or CCK is not stimulated and bile is not secreted into the small intestine, and bile backs up because it's not being used. So again, we've talked about this previously, but this is one of the many reasons why, whenever possible, we prefer to use enteral nutrition in place of parenteral nutrition. Humans are designed to optimally digest and absorb nutrients through their gut. So one of the side effects of prolonged IV nutrition is that paralysis of the gallbladder, or cholestasis. So the signs and symptoms of cholestasis include jaundice or turning yellow, pruritus, dark urine, and light colored stools. And so pruritus is an itchy sensation. And we've previously discussed, again, jaundice as well as the changes in urine and stool. So the treatment, so again, for a parenteral nutrition fed patient, we want to use what's known as a trickle or trophic feed. So we've talked about this previously from a GI standpoint. where we said that it can prevent bacterial translocation or leaky gut, again by keeping the bricks nice and tight to one another. So in essence, you're feeding a very small amount, about 5 milliliters per hour. That's 5 milliliters per hour. That is less than 4 ounces per day of total nutrition. But again, it's just enough to keep the cells functioning and alive. It also reduces our risk of cholestasis. So our second disease we'll take a look at is known as cholelithiasis. So again, this is gallbladder stones. So they may be in the gallbladder or in the biliary duct. And so when the bile is supersaturated with cholesterol, it crystallizes and gallstones are formed. So the fancy word for the stone itself is calculi. Just like calculus is very hard, so are these gallstones. Now with choledocholithiasis, one of these stones has shifted and slips into the bile duct. Because of the size of the stone and the narrowness of the duct, this causes an obstruction with pain and cramps. And so you may develop cholecystitis or inflammation of the gallbladder. The bile backup can lead to jaundice or secondary biliary cirrhosis. So here we can see some of the stones, and you'll see there are different types of gallbladder stones depending on the cause. So we have cholesterol stones, which may be green, white, or yellow in appearance. These are made mostly with 70 to 80% being a composition of cholesterol with calcium salts and bilirubin compounds making up the remaining 20 to 30%. And again, these occur because the bile contains too much cholesterol and not enough bile salt. And so here we can see the size of these stones is about 3/4 to 1 centimeter. We also have pigment stones. These are dark stones that are usually small. These are less than 20% cholesterol and are in the reverse ratio and are mainly bilirubin and calcium salts. And this is when we have excessive bilirubin production. So again, the growth of these stones, bile salts are concentrated with cholesterol in the gallbladder. Cholesterol remains in solution as it's not water soluble. Remember, it is fat-based. And the cholesterol can precipitate as gallstones. So imagine the same way that you grow rock candy, right, where you dip the string in the sugar solution and it slowly grows and grows and grows a crystal. But instead, we're going to slowly grow and grow a crystal made out of cholesterol in your gallbladder. Inflammation of the epithelium can cause excessive absorption of water and bile salts, which would normally keep the cholesterol in solution. Again, this is what triggers the initial growth of the crystal on the surface of the inflamed mucosa. But again, similar to that rock candy, the crystal grows larger and larger, right, as it now has a foothold or something to continue to grow on or around, forming large gallstones. Now we know how gallstones form. What we don't know is why certain people get them. Some people get many of them, some people get a few of them, some people never get them. So we do have our risk factors, which are obesity, diabetes, inflammatory bowel disease, cystic fibrosis, weight cycling, fasting, very low calorie diets, high fat diets, bariatric surgery, cholesterol lowering medications, genetic propensity. So as you can see, there's a lot of factors on both sides, from both too many calories and too little calories, but it really has to do with the concentration of the cholesterol versus bile versus calcium salts in the gallbladder. And so here we can see an example of how a stone would become clogged. That's our choledocholithiasis. So you can see the stones are in the gallbladder itself, but again, the stone may travel down through the duct and clog the duct. Now the treatment, so we have what's known as, for the stones, is a cholecystectomy. So if it is severe enough and repetitive, we may be required to remove the gallbladder. Nowadays, this is commonly done laparoscopically. So again, that's with 2 robot arms. One robot arm is going to go through the abdomen, one robot arm is going to go through your belly button, and again, the robot arms go in, they remove the gallbladder, and then will pull it out of your body. However, if you're young enough, if this was a unique occurrence with fasting, etc., and we don't believe this will be repetitive, then we may give medication to help dissolve the stones or antibiotics to reduce the inflammation. So gallstones often develop with low fiber, high fat, and high animal protein diets. So I'm sure Thais is very excited. Again, so what we do see is that plant-based diets may actually reduce the risk of gallstones. So again, don't get me wrong, it's delicious, but Chick-fil-A nuggets with French fries is a really bad idea and is definitely going to encourage the growth of gallstones. So we've talked about this a little bit, especially when we just looked at the previous photo on the previous slides. We have choledocholithiasis. So here the gallstones lodge in a cystic duct, common bile duct, or in the head of the pancreas, causing a biliary obstruction. So bile cannot be carried into the duodenum and is excreted in the urine, leading to dark urine and gray or clay-colored feces. And we will see maldigestion and malabsorption of fat and severe right upper quadrant pain. Now, along with that, we've talked about is cholecystitis, or inflammation of the gallbladder. Again, this has multiple causes, including obstruction, infection, or ischemia of the gallbladder. And this leads to a backup of bile. This can be a chronic or acute condition. So again, how frequently this is occurring. The most common cause of gallbladder inflammation is obstruction of the cystic duct by gallstones, which can lead to infection and necrosis. The signs and symptoms include upper quadrant pain, nausea, vomiting, and flatulence. Now, what we do see, and we spoke about this previously with a cholecystectomy, is especially if it's chronic in nature. So cholecystitis, again, is inflammation of the gallbladder, and what this may be caused by is repeated mild attacks of inflammation. In response to those chronic infections, that chronic inflammation, the walls of the gallbladder become thickened, and so the gallbladder actually shrinks, and so that the interior space, so when the walls get thicker and thicker, right, the amount of space in the gallbladder shrinks, and it cannot effectively store bile. So this requires a low-fat diet, as fat is going to aggravate the symptoms of the cholecystitis, as again, you are not able to store bile and secrete enough bile for the digestion of that fatty intake. This is in contrast to acute cholecystitis, which again is not caused by chronic mild infections, so this may need parenteral nutrition while NPO, and then resuming a low-fat diet as tolerated. All right, so we'll take a look at cholangitis. So this is inflammation of the biliary ducts, usually due to obstruction of the common bile duct, leading to infection. The infection can spread to hepatic ducts, biliary caniculi, hepatic veins, and can lead to sepsis. Sclerosing cholangitis can lead to sepsis and is a life-threatening complication. Treatment includes antibiotics, fluids, correction of blood clotting, and the placement of a biliary stent or a cholecystectomy. So in general, with gallbladder disease, things we're looking for are indigestion, decreased ability to digest fat, increased abdominal gas. Again, this typically leads to decreased intake and altered nutrition status. Again, every time these people eat, they're miserable. So again, it's very simple conditioning. If I eat, I feel terrible. If I don't eat, I don't feel terrible, in which case they're usually going to have decreased intake. So again, they're going to be NPO prior to surgery, and very commonly you'll see diarrhea post-surgery, but they should be able to tolerate an oral diet once the obstruction is cleared. Again, I would not have my celebratory meal after surgery be some extra spicy fried wings, but they should be able to pretty quickly resume an oral diet with some bland foods, your toast, your chicken noodle soup, rice, etc. Things to monitor is that weight and weight history, again, especially if they have a history of poor intake due to symptoms. Diet history, any comorbidities, keeping an eye on labs and meds. Again, we talked about, again, looking at, so with our labs, we may see jaundice, again, those elevated enzymes, etc. Possible PES statements for gallbladder disease include inadequate oral food and beverage intake, altered GI function, food medication interaction, increased nutrient needs, or excessive fat intake. So our interventions, again, is a low-fat, modest protein diet until the surgery. Small frequent meals may improve tolerance and thus improve intake. Again, though, still being NPO prior to surgery. After surgery, again, a low-fat liquids, again, slowly transitioning to a low-fat diet. And post-surgery, fiber, specifically soluble fiber, may help manage the anticipated diarrhea. Again, going back to, while not truly evidence-based, but our classic brat diet, where things like applesauce and bananas with soluble fiber are going to be low in fat and may help manage the diarrhea. Other things to monitor, we're going to keep an eye on our dietary tolerance, make sure there's no secondary infections, labs, and weight status. Now, when it comes to remembering who's most likely to experience gallbladder disease, we have what's known as the 5 F's. And so these are risk factors for the development of gallstones. So there's a very famous list, which is fat, 40, female, fertile, and fair. And so so especially when you see all of these risk factors in combination, this increases the risk of developing gallstones. So that is being overweight or obese, being near or above the age of 40, being female, being premenopausal, as it's believed that estrogen increases cholesterol levels in bile, and being fair, which is we see gallstones occur more commonly in Caucasians. And then lastly, we'll take a look at the pancreas. So again, this is located behind the stomach, opposite both the duodenum and the spleen. We've spoken previously about its endocrine functions, taking a look at the production specifically of insulin and glucagon, but that's not the only thing the pancreas does. So we do remember that it has 4 portions: the head, neck, body, and tail. And so the pancreatic duct merges with the common bile duct so that bile and pancreatic juices drain into the duodenum. So similar to the way that the gallbladder secretes bile via fuel injection into the duodenum, the pancreas will secrete juices and enzymes into the duodenum. So here you can see the structure, and again you can kind of identify the head, neck, body, and tail of the pancreas. And you can see, so on the picture on the right, you can see the ducts are kind of drawn in a little bit darker color, so you can see as they pass through the pancreas, and again how it secretes into the duodenum via the common bile duct. So again, the major functions we've talked about, so the endocrine functions, which produce the hormones, so glucagon, insulin, and somatostatin, which regulates the use of glucose or glucose homeostasis. So these are secreted into the blood or lymph. And the exocrine functions, which produce the enzymes for digestion of protein, carbs, and fats. And these are secreted through the pancreatic duct. So remember, what makes the pancreas unique is it is the only organ of the body that has both endocrine and exocrine functions. Now here we see a much better picture where we can see the ducts and how they move through the pancreas are then secreted into the common bile duct into the duodenum. So lab values we want to monitor when taking a look at possible pancreatic disease or pancreatitis. We're going to monitor amylase. So increased amylase in the blood is usually indicative of pancreatitis, and increased levels of lipase in the blood can also indicate acute pancreatitis. We also monitor white blood cells and liver function tests. So diagnostic criteria for pancreatic disease includes the MRI to evaluate for pancreatitis, and a CT scan to assess for fluid around the pancreas or blocked veins or possible obstructions. So pancreatitis, so itis being inflammation of the pancreas, can be acute or chronic in nature, with 30 to 60% of cases due to the lodging of a gallstone. Pancreatitis is characterized by edema, cellular exudate, fat necrosis, autodigestion, in which digestive enzymes attack, destroy, and digest pancreatic tissue, and hemorrhage of pancreatic tissue. That's bleeding of the pancreatic tissue. So acute pancreatitis, the exact mechanism is unknown, but common characteristics include autodigestion of pancreatic cells due to premature activation of trypsin. And diagnostics are based on clinical symptoms and elevated lipase and or serum amylase. And unfortunately, our major treatment is the tincture of time. So it will be IV fluids and then intensive care to manage inflammation, limiting secondary infections, treating any complications, nutritional support, and possibly surgery. So it's a lot of we simply watch and observe and fix any issues as they occur. So with our acute pancreatitis, we see 30 to 60% of cases with gallstones, alcohol 15 to 30% of cases, hypertriglyceridemia 1.3 to 3.8% of cases. Other causes may be things like endoscopic retrograde cholangiopancreatogram, or that ERCP. So when used to treat gallstones, if the surgery goes wrong, it may lead to acute pancreatitis. Maybe due to trauma, post-op surgical complication, drugs, smoking, cystic fibrosis, pancreatic cancer, or a family history. So signs and symptoms of acute pancreatitis, it may be asymptomatic until it's very severe. Upper abdominal pain radiating to the back that worsens with the ingestion of food, nausea and vomiting, abdominal distension, steatorrhea, hypotension, dehydration. And so here we can see what's known as pancreatic function test. So again, in addition to monitoring the amylase and lipase levels in the blood, there are specific tests to measure pancreatic function. And so the most famous one of these is probably the glucose tolerance test, which is assessing the endocrine function, so looking at the secretion of insulin and the sensitivity to insulin. But we also have, and what we see frequently in nutrition therapy, is the 72-hour fecal fat test or stool fat test. So here we're going to look at the exocrine function in the digestion of fat. So again, we would give the patient a dose of fat and then see how much is excreted, so to see how ineffective they are at digestion. So when we have a dysfunctional pancreas, things we're going to observe are going to be weight loss with fat malabsorption. With digestive complications, we may need enzyme therapy. We may see steatorrhea, which is that fat in the stool, and decreased vitamin B12 absorption and fat-soluble vitamins. So things to keep an eye on are weight and diet history, and following up on labs, specifically glucose, triglycerides, hemoglobin, hematocrit, white blood cells, and realizing that your albumin, prealbumin, and transferrin may be artificially inflated or depressed due to inflammation, as well as keeping an eye on lifestyle factors such as the frequency and amount of ethanol intake. Possible PES statements for pancreatic disease include altered GI function, inadequate oral food and beverage intake, altered nutrition-related lab values, increased nutrient needs, and impaired nutrient utilization. So our nutrition interventions for acute pancreatitis, we said again, immediate refeeding of oral intake, as tolerated, is found to be beneficial, starting with a clear liquid diet, progressing to a low-fat diet, and then progressing to 6 small meals. Again, because we have a diminished capacity or function of the pancreas, again, that also includes not only the exocrine function, but also the endocrine function. So again, we're going to have less enzymes, less insulin production. So again, we want to eat small meals so as we do not stress the pancreas. In severe cases, we may need nutrition support, so enteral nutrition associated with reduced infection, mortality, and the need for surgery, along with the maintenance of gut integrity, parenteral nutrition used to be the preferred method, but now enteral nutrition is gaining popularity, though some physicians may still use it, even if only temporarily during a severe attack. One of the beliefs is that parenteral nutrition is less likely to cause digestive issues. Now, the debate here is that if I place the tube well below the duodenum, how would I have the trigger for the gallbladder? So remember, it's a trigger in the duodenum. We have the release with CCK. We're going to communicate with the gallbladder. We have the release for trypsin. We can activate the pancreas. But if I don't have that signal, what would I actually secrete? Now, I have also had doctors tell me, though, that parenteral nutrition, so IV nutrition, would stimulate the gallbladder, which is always a very puzzling look. And if you're giving me a puzzling look right now, I completely understand, which is, how does putting something into your veins cause your pancreas to spasm or have diminished function in the GI tract? And the answer is, I don't know. So the other things we recommend is a low-fat elemental formula, again due to that lack of enzyme production from the pancreas, and again advancing to an oral diet once amylase and lipase levels decrease. Our second form of pancreatitis is chronic pancreatitis. So this is chronic irreversible inflammation leading to fibrosis with tissue calcification. So this develops gradually over many years. Again, we're going to see abdominal pain, nausea, vomiting, and diarrhea. The diagnosis is going to be made with mildly elevated amylase and lipase levels. So again, that's those enzymes have actually ended up in the blood. The patient may have diabetes. So again, long-term damage to the pancreas may also affect endocrine functions in addition to the exocrine functions, and we're likely to see steatorrhea, or that fat in the stool. So the most common cause of chronic pancreatitis in adults is alcoholism. So the most common cause of chronic pancreatitis in adults is alcoholism. The most common cause of chronic pancreatitis in children is cystic fibrosis. The most common cause of chronic pancreatitis in children is cystic fibrosis. 25% of chronic pancreatitis cases are of unknown origin, with 15% being due to genetic defects. And so our treatment, again, we're modifying behaviors such as reducing alcohol or smoking. We're going to treat the abdominal pain. We're going to restore digestion and absorption. Treating the endocrine insufficiency if necessary. So again, this is that artificial form of diabetes, in which case we're going to be supplementing, of course, insulin. And we may need proton pump inhibitors, H2 antagonists, or antacids to reduce the gastric secretion, as there's a decrease in pancreatic bicarbonate. So the pancreas is secreting less base or less bicarbonate, so we will be at a diminished capacity to neutralize the acid from the stomach. So instead, we will use a proton pump inhibitor or another antacid med to reduce the amount of acid from the stomach. So our goals or our interventions for chronic pancreatitis is to provide optimal nutrition support and decrease pain by minimizing stimulation of the exocrine pancreas. So goal 1 is optimal nutrition support, and goal 2 is minimize stimulation of the pancreas. So small meals that are low to moderate fat, so we do not have to secrete lipase. Again, MCT oil, which again can be absorbed directly into the bloodstream and does not require additional enzymes. Pancreatic enzymes with meals to improve digestion, and meds to reduce gastric acid secretions. Promoting weight gain is very common, as this patient population is oftentimes very underweight, because every time they eat, they have severe pain, they feel very ill. So if they are underweight, we want to promote weight gain, but if they're of normal body weight, we do not promote weight gain. And so our monitor and evaluation, our goal is to progress to oral feeds, right, and kind of get them back to as normal and best quality of life as we can. Now, if severe enough, and what you'll hear about is what's known as the Whipple procedure, also known as the pancreaticoduodenectomy. And so this is used for pancreatic carcinoma. So the pancreatic duct is reanastomosed to the jejunum. So I will take out a portion and then connect the pancreatic duct to the jejunum. And we may also perform a cholecystectomy, vagotomy, and or partial gastrectomy at the same time. And so this is going to depend on the severity, right? If there's cancer, if it is spread, etc., that we may need to remove several organs or parts of several organs to remove the tumor. We also have the possibility of a pancreatic transplant, which can also be done simultaneously with a kidney transplant. All right, so we'll take a look at some practice questions. So most liver disease in the United States is caused by A, blockage of the bile duct by gallstones, B, damage caused by drug metabolism, C, excessive fat intake and obesity, and D, chronic excessive alcohol intake. And I know we may talk about steroids a lot or other drugs, but it is not B, so drug metabolism. It is actually specifically, we're taking a look at answer choice D as chronic excessive alcohol intake. So chronic excessive alcohol intake is the cause for most liver disease in the United States. Patients with cirrhosis of the liver may have problems digesting fat, lactose, protein, or complex carbs. And so again, we know that while bile may be stored in the gallbladder, it's actually produced in the liver. So the correct answer choice is A, fat. So again, when you have scar tissue in the liver and you have decreased capacity of the liver, you'll have a decreased production of bile and problems digesting. Answer choice A, fat. Causes of ascites in patients with liver disease include A, inadequate intakes of sodium, potassium, and magnesium, B, fatty liver, aka hepatic steatosis, C, portal hypertension and hypoalbuminemia, and D, gallbladder dysfunction and fat malabsorption. The correct answer is answer choice C, portal hypertension and hypoalbuminemia. So again, I would recommend that you understand this process and how fluid is pushed out due to high blood pressure and poor retention due to low protein. So we see a buildup of fluid in the peritoneal cavity. Question 4. Patients with chronic cholecystitis often require A, MCT oil, B, a low-fat diet, C, a high-fiber diet, and D, supplements of fat-soluble vitamins. So in this case, right, we're looking at gallbladder disease. Again, the gallbladder stores bile with the primary focus on the digestion of fat by the function of emulsification and ensuring that you're able to digest fat properly in the small intestine. In this case, it is answer choice B, a low-fat diet. And question 5, the goals of medical nutrition therapy for patients with chronic pancreatitis are to A, decrease gastric acid secretion and gastrointestinal motility, B, decrease intake of simple carbohydrates and normalize blood glucose, C, provide optimal nutrition support and decrease pain, D, avoid the need for parenteral nutrition and steroid dependence. And so here, this was bolded, there were 2. It is provide optimal nutrition support and decrease pain. Remember, our goal is to minimize stimulation of the pancreas, right, while still providing nutrition. So it is optimal nutrition support and decrease pain. All Thank you, everyone. And again, if you have any questions, please take a look. The thread will be posted, so there will be one thread for attendance and one if you have any questions about the lecture. Please just let me know. Again, the Zoom session will be from 12 to 1. Thank you.